to start with mitral regurgitation. So first of all, if you direct your attention over this clip, this is what mitral regurgitation looks like. And this would be moderate mitral regurgitation right here. All right. So whenever we talk about any type of regurg, specifically MR in this case, it's when you have an incompetent mitral valve that permits backwards systolic flow from the left ventricle, travels through the mitral valve that's not functioning properly, and re-enters the left atrium. Notice on echo, this is the left ventricle in apical four-chamber. This is the left atrium. So in systole, remember in systole, the mitral valve is supposed to be closed. If you look over here, you can even kind of see that there's something going on with the valve here. It's not closing properly. There's like a weird little stoppage situation here. So what can cause this is rheumatic heart disease. If you have dilated annulus, because maybe you have dilated cardiomyopathy or anything that spreads the heart apart. Mitral annular calcification, like right here, it looks like the annulus is a bit calcified. That'll cause it. Flail mitral valve, prolapse, any type of stenotic leaflets. If you have a chordae rupture or elongation, and the chordae are the chords that are attached to the valves that help them open. If you have papillary muscle fibrosis, if you have calcification, if you have ischemia or a rupture, if you have infective endocarditis, if you have any type of vegetations, or if you've had a valve replacement, but that valve is malfunctioning, you'd have that situation. You can also have congenital anomalies, like a cleft mitral valve, which, remember, anytime you hear the word congenital, it means you're born with it. So if your annulus is dilated, the reason why it would cause regurgitation is because it displaces your papillary muscles and the chordae tendineae. So if you have any type of cardiomyopathy, coronary artery disease, or anything like that, that'll cause the annulus to separate a little bit, which will cause that MR. So there's two different types. You can have primary regurgitation or secondary regurgitation. Primary regurgitation is where the valve leaflets themselves are affected, and secondary regurgitation is what I was talking about with the dilated cardiomyopathy, where something else is causing the regurgitation, but the valve themselves are fine. So let's go back to talking about the chordae rupture. Sometimes the chordae, which are the little strings that hold your valves open and close, if they're holding the valve in place, if they snap, that can cause that particular part of the valve to not work properly. So if you have a rupture of a large cord, it can lead to like a flail leaflet, where the leaflet is like traveling into the actual atria in systole and back out in diastole. And this will lead to severe regurgitation. Also, for infective endocarditis, whenever you see a vegetation, let's say there was a vegetation here or like a buildup, you can say that the person has infective endocarditis. And that is an infection with the valve that directly destroys the valve tissue. So this leads to like a hole being eaten away at the valve itself. And so the leak begins because of that hole. Sometimes patients may have rheumatic fever, and it can start with like a strep throat infection. And then years later, it leads to damaging of the valve, because of the way the body reacted to that infection. And so it'll attack its own valves. And most of us, if you're going to get rheumatic fever, it usually happens as a child. And it's rare now for it to happen, but in third world countries, it still happens. So keep that in mind. In third world countries, it still happens, and it's the mitral valve that is most usually affected. So if you have rheumatic heart disease, it can lead to hardening of the actual leaflets themselves, and it limits the functions of the mitral valve, and it can cause both narrowing and regurgitation. So let's talk about valvular calcification. Sometimes this is because of the damage to the valves, but even as we age, there can be like a degradation of our heart valves, similar to the way the joints degenerate over time. And in some cases, this can cause the leaflet to become deformed and interfere with the valve function. So another thing that can cause regurgitation or damage of the valves is hard drugs. Now it's much less common, but if people are hard drug users, it can actually cause the person's valve to become damaged and they can develop mitral regurgitation. So let's move on and talk about the type of murmur. So the murmur for mitral regurgitation, for those of you planning on taking your echo registry, you need to know this because it'll help you pass. It's a holosystolic murmur that radiates to the axilla or the armpits. You may have a blowing or high-pitched murmur. Complications of this, you can have left atrial volume overload, you can have an LA thrombus, or you can have an embolization or an embolus from that thrombus. You can have increased preload, and that's the left ventricular volume overload pattern. And if you have a mitral regurgitation that's lasted a while, it could lead to pulmonary hypertension and heart failure. You can also have pulmonary edema, and that's where you have excess fluid in the legs. Direct your attention over here for a minute. Look how large the left atrium is. So when we talk about left ventricular volume overload, the volume of blood that was supposed to have left is coming back. So it's making the volume of blood in the left atrium more than it should be. So the left atrium is going to enlarge. So you will have left atrial enlargement, and that is going to increase the left atrial pressure. Because notice, blood is coming in, but blood is also coming in this way. So blood is entering from your pulmonary veins and also entering back from the valve, even though the valve is supposed to be closed. So that's going to increase the pressure and the volume in the left atrium. So I want to remind you guys again of what preload is. It's going to increase preload. Now, preload is the initial stretch of our heart muscles before it contracts, and it's related to how well the ventricle is going to fill. Afterload is the pressure against which the heart has to work in order to eject the blood during systole. Keep that in mind. So if a person has severe enough MR, they're probably going to have symptoms, and these are the symptoms. So you're going to have dyspnea, which is shortness of breath, fatigue, irregular heart rhythms, orthopnea, which is shortness of breath when you're laying down, and palpitations. So also for the treatment options, the first thing is the doctor is going to want to monitor it. Is it getting worse? Is it staying the same? They're going to do medical therapy. Like let's say you have secondary regurgitation where the valve wasn't the problem, but you had a different kind of cardiomyopathy that was causing the regurgitation. Medical therapy will help that. And the American College of Cardiology recommends that a person has mitral valve repair or replacement for primary mitral regurgitation if the valve itself is damaged, even if the patient does not have any symptoms. Remember the word primary. It means the valve itself is what has the issue, nothing else. So when you, this picture right here, you guys, this is a mitral valve replacement. This is what a mechanical valve will look like. So you're not going to see the left atrium very well because it's going to be, the valve replacement is going to be extremely bright or echogenic. So it's going to wash that out. So you always want to make sure you're doing a good job and you're able to see properly when they have these replacements. And this is when you turn on like either a pulse or continuous wave, you're going to see these clicks. Remember, a mechanical valve is going to have them for when it closes. So keep that in mind. So worst case scenario, if they can't repair the valve, they will replace it. And when I talk about valvular repair, it's to tighten that annulus and try to connect those leaflets better. And sometimes they may do open heart surgery, they may do a cath lab situation, or even a minimally invasive surgery. And now they have like robot assisted surgeries. And so the doctor will sit at a console and use robotic arms with like the surgical instruments to perform the surgery. And you can have what is called thoracoscopic surgery. And that's where the surgeon inserts like a long thin tube with a camera in like a small pre-made incision and then repairs the valve, which is also like attached like the instruments that they're going to need are already attached before they make that incision and put the probe into you. You can do like a mini sternotomy, and that's where they make a small incision in a person's sternum, and then the valve is repaired through that small incision in the sternum. And remember, you guys, the sternum, for those of you who don't know what it is, it's your breastbone, or the bone that lies in the middle of the chest and has like a T shape. So this is your sternum right here. That's why the skeleton is right here. So this picture right here, you guys have not scanned enough yet to see this, but like I said, this is a mechanical valve. So this is a replacement of the mitral valve, and this is the normal appearance. And you're going to have shadowing and reverberation, which is what this is. You're going to want to know reverberation for your registry. This is what it looks like. So when we image a mechanical valve, depending on the window that we use, you can always see these acoustic shadows. If you look at image A and B, so that's this one and this one, what we're showing is the reverberation on the atrial side. And for C and D, we're seeing them on the ventricular side. So just keep that in mind. And whether it's pulse wave or continuous wave Doppler, you're going to get this click and it's going to look like that. So let's talk about the 2D echo that we're going to be seeing. Remember, this is plaques, parasternal long axis. So we're going to be able to see the regurg is because of an anatomic basis defect, if they have left atrial enlargement, if they have that left ventricular volume overload pattern, if they have left ventricular hypertrophy. And when we talk about this, it means the left ventricular walls get thicker. And the reason why they're getting thicker is because the heart is now going to have to work harder and faster to get what little blood is in here out, because the body is demanding more blood. So you can have right ventricular dilation if this mitral regurgitation is bad enough. So this LVVO pattern, it's where the left ventricle becomes dilated, but the walls are hyperkinetic, meaning that they're squeezing real fast. Left ventricular hypertrophy, this is where the heart muscle gets thicker over time from working really hard. And right ventricular dilation, and this happens because the mitral valve regurgitation gets so bad that it starts to affect the pressure on the right side of the heart due to like the pulmonary veins and the connection of that. So I want you to keep that in mind. So you can have, the valve can be thick, you can have calcification, you can have prolapse, you can have dilation, a flail leaflet, or that chordae. So all of that can be happening, plus what we're seeing. So now let's talk about M mode. I have put what M mode would look like here for you guys. So this is, if you run in plaques, if you run the M mode over here on the aortic valve, this is what the aortic valve looks like when it's closed, and this is when it's open. This is your right coronary cusp and your non-coronary cusp. Now, when you move this over to where you're looking at the ventricle, just past where you have the tips of the mitral valve, that's what it's going to look like. So what they're telling you is these numbers coincide with what's going to happen when a person has mitral regurgitation. So I want you to look at, you can have the aortic valve notching, but that's that false early closure because it's not getting enough blood. On page 179, it'll talk more about that. You can have right ventricular dilation, left ventricular volume overload, left atrial enlargement, and you can have the pulmonary hypertension and the findings that come along with that, plus the right atrial enlargement. So keep that in mind. So the mitral regurgitation is not just all called mitral regurgitation. You have a severity scale. So you can go from grade 1 through 4. You can have mild, moderate, and severe. You can, we check this by using like the JET area, the LA area, and we use continuous wave Doppler to see how bad the severity of it is, and also how much it's affecting the heart. We use pulse wave Doppler. Well, we don't really use this much anymore, but they used to use it to map if they couldn't get a good continuous wave. But the machines are so good these days, you wouldn't have to worry about that. So the most popular way for us to tell if a person has mitral regurgitation is to use color flow Doppler. So when you use color flow Doppler, if the person does have MR, you're going to notice a turbulent systolic flow that's traveling back from the left ventricle through the mitral valve that's supposed to be closed back into the left atrium. So again, color flow Doppler is our friend when we're looking at regurgitation. Blood pressure, and also if you use the color flow Doppler gain, you can make something look worse than it is. And your blood pressure can also alter that situation. You always want to check the mitral valve from every view and give the doctor the highest numbers. So you can report the degree of the mitral regurgitation, but you only want to report it from, show all views, but report it only from the worst possible view. So we have grade 1, grade 2, grade 3, and grade 4 right here. So you can have mild, mild to moderate, moderate, moderate to severe, and severe. This is a cheap way of us figuring out where it is. If the jet is just beyond the leaflets right here, you say it's mild. If the jet is between, like right here, you would say mild to moderate. If the jet is 1/3 of the way to the left atrium, so 1/3 of the way to the back of this left atrium right here. So let's say right here, you can officially say it's moderate. If it's like maybe right here, you would say, remember you're cutting the left atrium this way. If it's like right here, you can say it's moderate to severe, like halfway into the left atrium. And if it's hitting the back wall or going into the pulmonary veins, you can say it's severe. So just keep that in mind. You need to kind of know how to look at them. So I have a few clips here for you to see the differences. So this one right here is mild. This one right here is trace because it's barely there. This one is mild to moderate. This is definitely moderate, as you can see. You can claim that this is severe, or you can claim that this is moderate to severe. This one is definitely severe. And in short axis, you can see it as well. I would say this is moderate to severe. For these two, you wouldn't measure like what we call PISA and all that for the mild ones. It's when you start getting into the moderate to severe territory, that's when it matters. So now, let's talk about the actual waveform for when you turn on the continuous wave Doppler to measure just how bad this is. So you're going to use a continuous wave Doppler, and you want the focus to be within the mitral valve regurgitation jet. Make sure it's parallel with the flow. When you turn on continuous wave Doppler, this is what you're going to get. Remember, for mitral regurgitation and tricuspid regurgitation, the flow is going to be below the baseline. Make sure we optimize that Doppler angle. We're going to compare all views. We're going to get the highest or the peak mitral regurgitation waveform, and we're going to check the strength of it, the shape, and the velocity. So you're going to get the MR VTI and the MR Vmax, and we're going to just trace this. So what we're looking for is the degree of filling. If you have mild mitral regurgitation, it's not going to be as bright as this. This is when you get moderate to severe. See this? This is probably like mild, and this is just extremely zoomed in. If you have eccentric jets, you may want to have the patient move a little so you can get a better window or better velocity. Check your Doppler gain. Don't make it too high. Don't make it too low. Usually, you want it to be 4 to 6 meters per second. If it's less than 4 meters per second, it means that the person has elevated left atrial pressures. That means that person has really bad mitral regurgitation. We would estimate the left atrial pressure from that gradient. The machine will do all this for you if you do your measurements. So the left atrial pressure is going to equal the systolic blood pressure minus the mitral regurgitation gradient. So if it looks like this, it means the person's mitral regurgitation is moderate to severe. If it looks like this, look at how non-bright this is, and look at how much brighter this is. So again, if the MR velocity is decreased in less than 4 meters per second, it means that the pressure in the left atrium is elevated because of significant mitral regurgitation. Now, if the pressure is elevated, we can estimate the pressure using the mitral regurgitation pressure gradient. So we take that systolic blood pressure minus the MR gradient to get the left atrial pressure. So I just wanted to show you, when you turn on that continuous wave Doppler, this is mild. This is mild to moderate. This is moderate to severe, definitely. And this, I'm gonna go with mild to moderate again here. You kind of, this one you wouldn't worry about measuring. This, if you want to, do not trace this. If it looks like this, you would trace it. Make sure you can see a complete jet before you trace it. So this one would be the least severe. This will be not as severe. This will be kind of getting bad, and this will be really bad. But again, you only trace when you can see a full jet. And this one, I can say you might get away with tracing. Don't trace this. Don't trace this. So let's talk about the pulse wave Doppler mapping. By the way, we do not use this method anymore. If your color flow Doppler is not good, you can use the pulse wave and put the gate in different places in the atria to get an idea of how bad the MR is. Why would we use it? It would be to avoid range ambiguity, meaning us not knowing how bad the regurg is. And we do this if we ever need precise sample volume to tell you exactly where the velocity is coming from. Unfortunately, because this is pulse wave, aliasing can occur if the velocity is more than half of that pulse repetition frequency. You'll learn all that when you start studying for your SPI. The higher the depth of that sample volume, the longer that PRF is, because the ultrasound wave is going to take longer to travel. So it's going to take a longer interval for us to be able to get that returning frequency. But again, we do not use this anymore. Now, if the mitral regurgitation is moderate and more, moderate or worse, we're going to do what is called PISA. And that is the Proximal Isovelocity Surface Area, or flow convergence. And we check it for coaptation defects. And when we measure PISA, we estimate the size of how bad the defect on that mitral valve closure is. So we end up getting the effective regurgitant or orifice area, or EROA. Now, one downside of PISA, it assumes that the place where the convergence is happening is a spherical shape. Like it's forming a spherical shape around the leaking part, which is not really the case. So in mitral regurgitation, you're going to turn on color Doppler and you're going to get something that looks like this. So right here it says flow convergence. What that zone is, it's the zone of increased flow velocity right before the regurgitation, like the opening where the regurgitation is. And we're going to talk about vena contracta. That's this right here. And vena contracta is the point in which the valve, like where the diameter of the valve is the smallest, and the blood velocity is going to be the highest, because the blood has to travel there really fast because it's really tiny, the space. Then we have regurgitant orifice area, or effective regurgitant orifice area. That is simply saying it's the narrowest area of where the actual flow is happening. So what we measure is what we call PISA, and that's what this is. We measure from here to here, and that is the Proximal Isovelocity Surface Area, or PISA, of a regurgitant jet. But we get that with color flow Doppler. So we use it to estimate valvular insufficiency, and it's based on the actual hemodynamics of flow through like a small circular orifice. It's not quite circular, but the math behind PISA assumes that the flow is. The PISA, you're going to be measuring from here to here, but you're going to want to zoom in. So that's kind of something you need to remember. So it'll look like this, but the person zooms in, and then we measure the PISA. So right here, whenever we are doing this, we're not going to adjust the color flow scale. What you're going to do is you're going to shift the baseline down between 20 and 40. I normally don't go past 38. 30 would be the maximum that you'd want to shift that baseline down to for you to accurately measure the PISA. So you're going to get the radius. That's from here to here. Remember, I told you would zoom in, right? This is the PISA. And you're going to get the MR Vmax using the continuous wave Doppler. That's when you trace down here. Remember, I told you guys, if it doesn't look like this, if you can't fully see the waveform, you do not trace it. And you're going to want to get the aliasing velocity from the color flow map, and you're going to calculate the effective regurgitant area orifice with the continuity equation. You don't have to do this. The machine will do it all for you. But these are the three things you need. You need the PISA, you need the MR Vmax by doing the tracing, and then the machine is going to give you this. Remember, again, I don't go down past 30, but normally I stay at around that 38 range, which is correct right here. So their book says 20 to 40. I wouldn't go down to 20 because I don't think you need to. So if you have severe mitral regurgitation, some of it might flow back into the pulmonary veins. So the reason why we would check this, we check your pulmonary veins, and it's dependent upon the pressure difference between the pulmonary veins and the left atrium. Remember, when you have mitral regurgitation, that's going to increase the pressure in the left atrium. So when you bring the pulse wave Doppler down here, I know this is a circle and it normally looks like a continuous wave Doppler, but it's pulse wave that you're doing here, not continuous wave. So when you put the pulse wave Doppler in either one of these, like they've done right here in this picture, this is what it's going to look like. So you're going to get it in 4-chamber, 5-chamber. Just know that you have 4 pulmonary veins returning to the left atrium. In 4-chamber, you see your right and left lower pulmonary veins. In 5-chamber, you see your right and left upper pulmonary veins. You want a small range gate, and you do not want to go more than 1 to 2 centimeters into the pulmonary veins. Remember, the pulmonary vein flow into the left atrium is going to depend on that pressure difference. If there's a lot of it, it's not going to be able to put blood into the atrium like it's supposed to. So what you're looking for is you're going to get a S wave or a systolic wave, which has an early systolic component, which is this S1 right here. You're going to have a late systolic component, which is this S2 right here, and it's going to be followed by the diastolic component, which is this D wave right here. And then during like the atrial contraction, there's a flow reversal, a small one, which is called the AR duration. That's this right here. This is that A wave, AR wave. So S wave, you don't always get an S1 and an S2. Sometimes you just get an S wave, a D wave, and an AR wave. Just keep that in mind. Look at this picture again. You're putting the pulse wave Doppler 1 to 2 centimeters into the pulmonary veins. No more than that. So when you use your pulse wave Doppler, this is what your flow is supposed to look like. So this is when you put the pulse wave Doppler at the tips of the mitral valve leaflets, not the pulmonary veins. Your E wave should be taller than your A wave if it's normal. If it's abnormal, like abnormal relaxation, your E wave is going to be shorter than your A wave. Under normal circumstances, when you put that pulse wave into the pulmonary vein inflow, you're going to get your S wave, your D wave, and your A and R wave situation. And for an abnormal, this is what you're going to get here. By the way, these are the stages of diastolic dysfunction. Do not worry about them right now. You have normal, you have pseudo-normal, you have abnormal, then you have 2 different types of restrictive filling. But notice as the pressure increases, look at how the waveforms are changing. We will talk about those specifically at a later time, not right now. Right now, I just kind of want you to see that the pressure does change what the waves look like. Both your E and A wave and your S wave, your D wave, and your AR reversal.
If this helped you, subscribe so I can keep helping. Don't miss the next video.
This is what your book has, but this is what it looks like in real life. Your S wave, your D wave, and your AR reversal right there. Again, just keep that in mind. Now, 1 and 2 is a normal pulmonary vein systolic component. Remember, the systolic component is larger than the diastolic component in a normal person. S wave larger than D wave. When you have moderate to severe mitral regurgitation and that pressure has increased, you're going to have a decreased S wave and an increased D wave. So remember, that's telling you that it's moderate to severe. Notice you still have that A wave reversal. When you have severe mitral regurgitation, the S wave itself might reverse, and you're going to have an increased D wave. And that's that pulmonary venous systolic flow reversal. That's what we call it. And that means that the person has severe mitral regurgitation.